Hey guys, so I'll get started. I mean, it's a couple minutes early though, so maybe we'll wait 2 minutes. But Jean asked me to stay within my confines. She said Dr. Z escaped his confines and screwed up the audio. So I'll try to stay in my little cage here and give this talk. It's a pleasure being here again, and in person is even better. I'm really glad we're all here and can see this. It's just an amazing conference. You guys do, I mean, I have 2 minutes. It's an amazing conference. Just for the patients to have a community and just be together. I mean, I think that's just unbelievable. I mean, I've met patients with arthrogryposis who've never met anybody with arthrogryposis before in their lives. In fact, before I get started, I was sitting in a restaurant at a place in Massachusetts, and we're eating breakfast, and obviously the man next to me had arthrogryposis, and of course my wife looks at me and goes, "I'm not going to say anything." And Jen goes, say something. She goes, by the time we left 2 hours later, Jen had been speaking to them for 2 hours, and he had never met someone with arthrogryposis. So when I was watching him eat, and that was actually fun to just see how he compensated, and it was really lovely. So I'm going to mostly talk about, the impetus of this talk of Keep the Joints Moving is really the combination of working with both our physical therapist headed by Fran Guardo, our occupational therapist headed by Mary Becken. They're here today, and really keeping the joints moving. Arthrogryposis means stiff joints. So the goal of the treating people and for families is to keep those joints moving. And how do we do that? How do we keep a stiff jointed disease moving? And that's what Dr. Z was just talking about, and that's what I'll be talking about as well. So I have no conflict of interest in this talk. Okay, we all agree that basically we know that AMC or arthrogryposis is basically created from, oops, I gotta somehow shut this off, guys. Hold on. How do I volume off? I don't know this computer. Oh, there we go. Okay, I won't be speaking anymore in the background. So I guess someone take this talk. So anyway, so basically, we all agree that it's a stiff jointed disease. We know it's difficult, and there are certain synonyms associated with arthrogryposis: amyoplasia, arthromyodysplasia, and there's associated syndromes with them. And all of these really should be under the category of arthrogryposis, meaning that there are Larson syndrome and Sheldon Hall and Martin Walker and popliteal pterygium and Escobar and diastrophic dysplasia and Otto syndrome. All these syndromes are part of arthrogryposis. And the longer we do this, and we have a geneticist working with us, we know that we're going to find the causes more and more. And perhaps AMC used to be thought of as being 85% of the reasons why someone has arthrogryposis, but perhaps it's only 15%, and everybody else we can actually find the cause for. So we know it's stiff joints. We often know we don't know the cause of it, and it may be genetic. So let's keep the joints moving. So let's go through that. So I think Fran and Mary are going to talk about the earlier intervention, and this is a talk they gave on Facebook for us. And I'm not going to go through this, but treating the baby early on, like actually I'm going to show this. Willa, you're going to be up here. Dr. Z was just showing you, is really hard, is really important. So this wait and see thing is really not appropriate. Don't wait and see. We don't have to wait and see. We just have to treat the child. And I think what they're going to talk about is unlocking them early. And there you are, Willow, and that's actually not Willow, that's actually somebody else, but that's Lucy. Part one is Willow. One in the middle is Willow. But basically, how do you unlock these little children? And that little girl in the middle is sitting on her mother's lap right now playing. And was sitting with Dr. Z. And basically, you saw just how well the therapist did, and perhaps we all did, in treating her now that she's playing with her mom's phone and calling people she doesn't know. So early intervention in that first year of life, before we put them to sleep, and I agree with Dr. Z, I don't like putting kids to sleep before a year of age. It worries me. But after that year to two, when the elbow has to be released, you have to unlock them before that. We've got to make them as good as they can be. Avoid the surgeries that they may need. And really that early intervention, wherever you are in the country, Zoom works, videos work, phone calls work, and you can get your therapist to work with therapists who are aware of how to do this, to unlock these children, unlock them now, so that it'll make it easier. And there's so many different modalities that they'll talk to you about. Kinesiotape, HEAT, ASTIM. I know, I stole your talk. I'm not talking about it. But how do I keep the joints moving? So now I will leave Fran's talk, and I will go to my talk. So basically, how do we keep the joints moving? How do we do it surgically? And what do I mean by that? So let's start with the knee. The knee can move into, it could be stuck in flexion, bent, or it could be stuck in extension. We can't make muscles yet, and that's going to be the big discussion for everybody, right? If you don't have the muscles to do this, what do you do? And I can't answer that question. I mean, there are transfers, and we're working on this, but I love the analogy of that it's like buying bricks. If you put stem cell in there, well, you don't have a house, you have bricks on the lawn. So I do think that we don't know that answer yet of how to bring a muscle that doesn't exist to bring it somewhere else. So if the knee is stuck in flexion, very hard to walk. It may be easy when you're 1, or a little bit easy if you're 1. It's a lot harder if you're 13 and you have some weight on you to try to walk with your knee bent. If your knee is extended, well, that's really adorable, you can walk, but when you get older, you don't want your legs stuck in extension. You can't sit at a desk at school, you can't go in a car, you can't go on an airplane, you have trouble sitting at restaurants, you trip over people trip over you. So I think knees stuck in extension sometimes is more functional, but not very useful as you get older. And it's a very big, and patients come to me at older ages, and what do you do? So how do we keep the knee moving? So that was my real goal when I got down to West Palm Beach from NYU. I wasn't happy how we treated AMC in general, and so I basically devoted the last 7 years to making knees move. So we started with these flexion deformities of knees, and these are 2 different patients, one an 80-degree contracture, one a 70-degree contracture. And we figured out, without using fixators, because that made the knee stiffer for me, is how to get the knee moving. And this is the potpourri of, or the list of things we do: releasing the joint, freeing up the nerves, not lengthening those, but freeing them up so they don't get trapped, because that's a big problem in general. Upper and lower extremity trapped nerves is a big deal. And I wish I knew which patients had that at birth, because probably we should be releasing nerves very early. And then shortening a bone helps you release. So you saw the patient that Dr. Z showed you with Escobar syndrome, the one who had the pterygium of the elbow, the webbing of the elbow. You can't release that because the elbow will look better, but the elbow won't straighten, as he said, because the nerve in the artery is too tight. The only way to make them looser would be to shorten the humerus. So you can do that. Like you can shorten the femur of the thigh. And if they don't become shorter, it's probably zero-sum gain, because you want to keep the nerve about the same length. So you basically are just making the nerve and the artery not tight so they don't lose their limb, and everything moves so much better. How does it work? Well, you basically globally reduces the soft tissue tension. It relieves pressure on the nerves and blood vessels, and you can rotate the leg if it's rotated one way or the other at the same time. So this is a child I'm going to show you. This is a 90-degree contracture. I did this when I was traveling abroad. This was in Israel. And basically, here's a child who has 135 degrees of flexion. He's stuck at 90 degrees. He cannot move, he can't walk. And basically, that's the operation. He goes from 90 to 0, but it's not about going to 0. It's not about going straight. It's about that he can keep moving. So there are no casts. So unlike Dr. Z, even for the elbow, which I'll get to, you have to get the knee moving. You have to have therapy. So you can't do this in London because they can't do therapy afterwards in England. So if I didn't have my therapist working on these kids the week after we did this, or wherever we are, they're not going to do well. So it's not just about getting it straight. Yes, we can get it straight, but the younger we do it, the golden age for this is between 18 months and 3 years of age. That is the golden age to do it. It can be done older. It's harder. I don't think the results are as good, and there's things you can do if that doesn't fully work, but you've got to keep the arc of motion. You must keep the arc of motion. So this is the child afterwards. Those are the rods, which is one trick you can do to keep the elbows moving too. And so there's no delay, there's no cast. There's the patient with a straight knee on one side, a bent knee on the other. There he is showing that there's no contracture anymore, and he had full flexion and full extension, and he walks fine. Here's a little baby. So, let's really shame it. Yeah, the video. So she has some muscle strength, but she has knees stuck. You can see there's your little baby. Here she is walking prior to surgery. Right, but that's not functional ambulation. That may be okay at 2 years of age. That is not functional ambulation. And so that is a problem. And so how do you get them to be functional ambulators from being 60-degree contracted? And here are the braces holding them, but they're not going to do this at 16. So there she is before. There she is in the operating room. There she is in the operating room. She had previous surgery before me. And there she is in the operating room. And that's it in the operating room. So that's the knee. And that was when I did one side at a time. Now I do both sides on these kinds of kids at the same time. But that was 3 weeks before we had done that side. And that's her knee bending and extending. And that really almost keeps it in most kids. Not all, but that keeps it in most kids. That's after we did one side versus before we did the other side. Actually, I have permission not to block their faces for this picture. So there, I got permission. So there she is walking up the steps, which I think is pretty incredible. This is only 6 weeks post-op. So here's the videos. So there she was before. This is 2 months after surgery. She was 3 when I did the first case. She's now, I think, 6 or 7. That's her now. That's here about a year ago. And that's her walking on a treadmill. She's 9 now? She's 9 now. And that's her. So I think that, look, am I showing a great case? Yes. Does she have quadriceps? Yes. If you don't have quadriceps, then she could do the same with a brace. And I've many, many kids who have braces on. And I don't know why you don't need such great quadricep strength to walk without braces, but you don't. This is a young girl I met at this conference. I'll show you that because I met her in Norfolk, Virginia. And she's all over the internet, so you might as well take a look. So this is her before, or maybe this is in Norfolk now a year later. This is in Norfolk a year later. I saw her at the conference here again. Up, come on, walk for me. All right, I'll show you this video instead of my wife. She's teaching my wife how to stand and sit and stand and sit. But you really gain function, and she walks fine. I mean, she ambulates without brace, with just AFOs, and she does it all. So that's her teaching her to walk. Okay, so let's move on to the straight knee. How do you get the straight knee to flex? Harder. And I didn't know that I could do this. And we really have now come up with ways of making the straight knee flex, because what I was taught was that a quadriceptoplasty works. So you can actually lengthen the quadricep muscle, and that'll get your knee bending. But most of the time that doesn't work. This is a young girl I treat from Poland, and she wanted her legs amputated. She wanted to, for me, she was a normal intelligence, and she was, and she was very smart and went to go to school. And she came in for me to amputate her legs above the knee because she didn't want her legs sticking out anymore. And I said to give me one try to do this, and that is her. And this is me following up with her 6 months later in Poland. So yeah, these are not little surgeries. These are very big surgeries. And the therapy afterwards, we have our own center for therapy in Poland. So we do that. That's why we do it for the Europeans. We do it there. But, basically, this requires a lot of work. But there are ways of doing this. And I think that it is not a Jude quadriceptoplasty, if anybody knows what that is, because I can get the knee bending to 120 degrees in the operating room, but I can't keep it bending even with therapy, even with casting. So there's other ways of doing this. And you do is you shorten the femur distally, you can raise the tibial tubercle. There's different tricks you can do, and I think we're getting a lot better at extension contractures than we were before. Okay, what about hip flexion contractures? So I'm keeping this, how do we keep the hip moving? Okay, this is controversial for this conference because I don't think you should do hip osteotomies. So a lot of kids are born in that frog position, right? The kids are born all the way with their legs up. Their knees are flexed and their hips are flexed all the way up to their chests, and they're stuck like that, stuck out like that. And it's very scary, because it's not functional as an adult to have your legs all the way stuck up in that position. So the question is, how do you keep the hip, how do you get the hip into position? So the first thing you do is you begin early intervention. And that's the first thing, because gravity will help you. At birth, the child with arthrogryposis, as you all know, looks the worst. That's the worst the child's ever going to look in their lives. So it's really key to look at the child and say, okay, breathe a little bit. Let's figure out how to do this. Don't let them do anything in the hospital, including break their femurs, which happens all the time in the nursery, right? They try to straighten the child out and they break the femurs. I was even at a birth recently at our hospital because the parents asked me to be at the birth, which I will never do again because I was scared. I was completely scared, just so you know. The OBGYN had me scrub in for the cesarean section. I almost passed out. Basically, I was basically sitting there as they took the child out. Really, I needed like oxygen at the end of it. But anyway, the truth is that, and I went into the ICU after. They said, "Okay, don't change the position of the change station." They did, and they broke the femur. I mean, it's fine, but you don't. So you don't have to bring the legs around so quickly. Give it time. Give it a year and a half to get the legs down. Stretch it out. Let gravity work. Let the therapist work, and then we'll work on the knees as well. And then at the same time we do the knee, we can actually release the hip. And instead of breaking it to put it in, because that's not functional when they get older, you can actually, and I have to reverse it all the time, you can actually just release the muscle off the pelvis and bring the hip down. If you get the knee straight, gravity then brings the hip down. And I think that's, and almost always if you do it before the age of 3, even before the age of 6. So I don't put plates and screws in the hips. I just release them at the same time as I do the knee. Because it's a big surgery, sometimes then you do one side and you do the other side at a later date. So no osteotomy of the hip. For flexion release in front, shorten that side of the pelvis. PT. I can't tell you enough how much therapy plays a role in this. As Dr. Z said, for the arms too. For extension, it's very difficult. But the knees, the hardest one for me is the hip stuck and it won't flex. Because then you can't sit. And then you've got to bend your spine and make this like curved back, it's called kyphosis, to sit. There are tricks to that too. Doing a release behind the hip is one. Seeing if the hip is dislocated in the front is the other. So there's different tricks you can do. And I think it's becoming more impactful. And the other one is you can do a pelvic support when they're older. When you actually take out the hip and you make the top of the femur the hip joint and start moving that. And that's actually a very successful operation if the child is above the age of 9 and can sit. And the biggest problem will become if you have scoliosis, you need scoliosis surgery, and then your hip doesn't flex. How are you going to sit in a chair? I mean, you have to lean back so far to sit in a chair, and that's not an insignificant problem. And I can't tell you enough how much I think that plays a role in my thinking of how I'm going to get people to sit if they're primary sitters, how do you get them to walk if they're primary walkers, and then having realistic goals for both, for the hips and the knees. And I'll get to the ankles in a minute. Dr. Dobbs, my partner, one of my associates, spoke about some of this, but I'll get to that in a minute. But you can keep these joints moving, and I think that in varying success of getting function depending on how much muscle you have, but it's amazing how well the kids can do. Elbow contractures. So I'm going to give my talk. I know Dr. Z just spoke about upper extremities, but I'll give a little bit. Stuck in flexion you can treat. You can get elbows, especially that have been treated before. I was just telling him what to do when he left, that are stuck at 90 degrees. So I disagree with one thing. Nobody I know, and you can correct me if I'm wrong, wants one arm flexed and one arm extended. You want bimanual. You want your hands in front of you. This thing that Dr. Izaki, who I loved, talked about is like so painful. It's like, you're stuck. You're sort of like, you don't know what to do with yourself. So doctors should stop saying it because it really is not true. People want their arms in front of them, and they don't want one arm bent and one arm flexed. It's just a mistake. That was a mistake that's been carried on for generations, and we should just stop saying it. So you want your hand, and so you can treat an arm that's stuck in flexion if it's been previously operated on. If it hasn't been operated on before and it has a web, I was saying you can shorten it like we do the femur, but it's a trade-off. So either you leave it, and because it's much harder, because what's stuck is not the joint, it's the nerve and the artery. And so how can I straighten it when you need that for your fingers? So you don't play piano with your toes, but your fingers you need to work a lot better. Extension, I think he discussed at length. I think the only difference I would say is that we don't really cast the elbow. Maybe we put it in a week in a splint and then get it moving really early. And the reason we can do that is because we use a rod for the humerus, which you should do, and so you don't get refractures. I got 2 refractures, so I stopped using just plates. And then you just put a rod in with a little plate, and they shouldn't refracture. If they do, the rod's in there if they fall anyway, and you don't need to change anything. So just keep them moving. And I think that everything Dr. Z said is true. You do the posterior release, you get the ulnar nerve, which is stuck. There you are, Willow. And they're basically stuck in the with your elbow flex, and you keep them down. And you've got to get above the 90. You've got to get to that 90 to 100 degrees. Cast, splint, dynamic splinting. You got to get that 100 degrees. And it is torture therapy. It really is. I think that the easiest explanation I can give for any of this is if anybody who's sitting in the room is being supported, doesn't have AMC or arthrogryposis, has ever been in a cast for 4 weeks. So I broke my ankle when I was 14. And they put me in a cast for 4 weeks. And then they took me out of the cast and told me to go walk. And I never remember any more pain that I had in my ankle than putting my foot on the floor that moment. And moving a joint that's been stuck in a cast even for 4 weeks is incredibly painful. Could you imagine being stuck like that for years? And then someone just all of a sudden moves the joint. The amount of pain that is. And the elbow is the big one. The knee's not great, but the elbow, I think, is the worst joint for moving. And the kids are in pain for a while afterwards, so they have to sort of live through it. The parents need some anti-anxiety medication. But basically, this is, her trying to use her arm, but basically one flexed and one not going to 90. And I think that the wrist is something we'll discuss in a minute. And there you are again. They sent me some videos of you, but you saw her already, so I'll just show it again. But basically, try and get the elbow and try to take her candy up. She can do it. So she's more than 90. Okay. Exactly. So that is the key. Can you do that with your hand? That is actually that is why we do this, right? So you can function in everyday activities of daily living. And so this is my young girl that taking credit for this one. This was the first latissimus done in North America for 30 years. So this girl who is, I forgot how old she was here, maybe 8 or 9, can't move her elbow. She can flex it, but she has passive range of motion. So this is the video before. And I like this because I just saw her this week because she did something for her legs. But there she is trying to write, but she can't bend. And she can sort of and that's a very good motion, right? We all know that one. Extended arm, flex. If you have passive motion, that's how you eat. And that's actually a go-to method, but you can't eat an ice cream cone because you'll throw the ice cream cone against your face. Unless you go really slow with the other arm. But you can figure out ways. So this is her before. That's a disgusting picture showing how big a latissimus operation is. It is a very large operation, like Dr. Z said. It's not a large operation in terms of the surgical procedure. You don't lose a lot of blood and it's okay. But it's a big scar. But it's not as disfiguring as latissimus. So as a pectoralis major. So he talked about the lower pec transferring it for flexion. And that actually works. The problem with putting a big scar on anybody on their chest, a woman or a man, is very disfiguring. And I think that Scarman had that, and he showed it to me, and his worked actually pretty well until it ruptured when he was in his 50s. But basically, it's a pretty disfiguring scar, and especially for a woman, it bothers me. So that's why we started using latissimus. This is at 12 weeks, 2 years, and yesterday. So she let me show you. Right, so that's what latissimus does, and that's proof of the concept. So I've done about a dozen of these now, and I think that they are, if you have one, the problem is, does everybody have one? And it really is, not everybody has one. If they don't, then really the best thing is to do is use the extended arm and just get the passive motion and learn to use it. Because I think the other ones, the triceps and everything else, just keep the motion and do something else, but it doesn't work. Okay, the wrist. So I didn't know he was giving this talk right before me, but I'll talk about mine. So the one thing I'll talk about the wrist is that most often it's flexion, and that's quite good. So how do we keep the wrist moving? So one operation he didn't discuss, so I almost never do a carpal row because it makes the wrist stiff in the long run and it comes back again. So I don't like doing the carpal row unless the patient really has a very flexed wrist that functions much better in extension and has a good elbow. Because the problem with making an extended wrist, if you have an elbow that's limited, is that you can feed your ear, but you can't feed your mouth. So you're stuck with it. Having it bent, at least it goes to your mouth. So bent is good. So what we started doing is an operation that we did for cerebral palsy, and which I grant Mary for this because she was made to me do these, is that we release you release one tendon from the arm and release the nerve called the ulnar nerve, and then put that tendon to the wrist, so you lose no passive motion. This is after this young boy had one before I did the other. And it's really not a big operation at all to get over. It's actually a pretty small operation. And it's a decent sized scar. And you pick up, and it basically, just soft tissue wise, allows the wrist to be in a better position. And also I think releasing the nerve gives the children better function of their hand. But I can't prove that. I've got to prove it. So this is working with him. He had no function of his hand prior to this. Just showing how he's starting to use his hand. And this is our therapist, Miranda. And he's also feeding. He didn't do it. But you can see he's just starting to use his hand, while before his wrist was stuck and could not be used at all. And there he got his lollipop. And Miranda's proud of him. Okay. So I think that, it's a pretty small operation. And the good news is you don't need to have the muscle. Actually, I knew this from the ankle. We transfer something called the posterior tibial tendon, which we transfer from the inside of the foot to the top of the foot to give you the ability to move your foot to the top of the foot. And even if it doesn't work actively, it acts as like a check rein. It acts like a little tether to prevent the wrist from going down. I think that's really important part of this whole process. So I really like that operation when Mary makes me do it, and really, because she's our therapist, I never do it without her permission because I'm never 100% sure. Okay, so the ankle movement. So that's really a good question. So I would say 90% of the kids I see, 90% of the kids I see with arthrogryposis do not have active dorsiflexion of their ankles. They can't move their ankle up, right? They can barely move it down also, but they can't move it up. So the key for the foot when you're an adult, as an arthrogrypotic person, is number one, most adolescents don't want to wear AFOs, right? They hate them. Girls and boys hate braces in general. But, and two, you have to have your foot almost flat to the ground. If you want to wear a little heel, maybe you could have, it could be a little bit slanted. But it's hard to walk all the way up on your toes. And so the ability to get your foot flat on the ground doesn't require ankle motion, right? It requires your foot to be flat on the ground. In fact, if you have motion, then you have to wear a brace. Because otherwise, the foot just falls down and it gets in your way. You got to lift up your leg further. It's called a steppage gait. It's made out of like cadets that when they walk with a high step gait, because you have to step high to clear your foot, otherwise it gets stuck and you fall. So you want your foot almost 90 degrees to the ground. So I don't know yet how to keep the ankle moving, right? I get frustrated with club feet because they come back, and I don't think casting every year for 6 weeks is non-invasive. It's invasive. It's invasive for the family. It's disruptive to the child. It's disruptive. It creates PTSD. It takes the child out of their element. It makes the child stop walking. It weakens the bones. So I don't think casting like telling somebody you've got to come for casting every 6 weeks, every year from the age of 2 to 9 is not disruptive. It's very disruptive. So you have to find a way not to do that. So there's some tricks I think about how to do that, and we do use our therapists to keep on giving exercises and correct bracing. And at some point, you just fix the foot in position and you tell someone to move on with their lives and get on with it, because they don't need a brace anymore, and it makes it a lot easier. And I've done that many, many times, and we'll publish on that. So I think the most important thing of an ankle is my one time, I'm not keeping the joint moving because I don't know how to keep the joint moving. I don't think anybody does. I just want to get into position. So while I say keep the joint moving for joints from the mandible to the knee, from all the way up and down, I don't think I can keep the ankle moving. Okay, the last one I'll show is because I want to give equal time for other people who have conditions with arthrogryposis, like Larson syndrome. This is a young girl who was adopted, and she's this beautiful little girl. And I will show you, this is before, and all she wanted to do is to be able to walk. So she's tough. Now, the advantage is she has muscles, right? So, like, this may look like a really hard thing for a surgeon, but this is actually, I think, easier because she has muscles that actually work. Same with Escobar, same with some of the AMCers, and some don't. But this is her now. She just sent me this a couple weeks ago. So, I think that it can be done, and I don't think there's really no limit, but I think that there has to be a will, and there has to be a, therapist to support you, parents who have the resources to be able to do something like this, and the will, and then, the child who wants to fight hard for it, and the surgeons who are willing to listen to other surgeons and willing to listen to other people. I learned a lot today from this lecture before me. I think we have to keep on evolving, and we get back to Russia, let's see what the Russians are doing. Let's go to Taiwan and see what the Taiwanese are doing, with free muscle transfers. And let's see what stem cell, listen, if someone tells me they have an answer for stem cell, I'm open to it. I have no part of this, and I don't hear that there's enough, because we don't have all the answers, we don't. And there are failures in all this. We did publish our lower extremity results, and they're really, really good. We did our first 160 now, that we reviewed, so it's way more than that now. So I think that we have some answers, but we certainly don't have them all. And that's why I think the next for us will be an arthrogrypotic meeting for some parents if they want to come, but mostly for doctors to talk amongst each other, and therapists and caretakers and everybody else, to see if we can come up with some guidance, or what tricks are you using to solve, what problems you have, and what solution can we come up to that problem. Is this gracilis transfer that Dr. Z does, is that going to work? Is that free muscle transfer going to be? Or should we be taking nerves at a very early age and putting them into something we think is muscle? So I'll give you one example as I'm finishing this. So I have a patient from Pakistan who, number one, just tell anybody with AMC, get an MRI of your spine early on, because you may be tethered. Because tethering of a spinal cord is something neurosurgeons won't talk about, but it's a big deal for AMC and arthrogryposis. And it is a huge functional problem. So I have to fight with we have an amazing neurosurgeon now working with me in Palm Beach, but I had a great one in New York. And I fight with neurosurgeons from around the country about detethering spinal cords, because their indications for detethering spinal cords are not the same as mine. So what does that mean in English? A tethered spinal cord means at the bottom of a child's spinal cord, there's a little thing called a flound terminality, which looks like a rubber band. And it doesn't allow the spinal cord to grow with the child. So all of a sudden, the spinal cord becomes tight, so the nerves become tight. So it can affect your bladder and bowel function, it can affect your extremities, it can give you club feet. A neurosurgeon wants to see a progressive loss of bladder and bowel function to release a tethered cord. That is not what a pediatric orthopedic surgeon wants to see. We have club feet and we see a tethered cord. We want them to be released because we don't want the club foot to come back again. So we don't detether spinal cord, so I have no vested interest in whether I do it or not. But the neurosurgeons need to detether the spinal cord. So I think my neurosurgeons detethered 60 spinal cords in the last 4 weeks of my patients who came down and didn't know their spinal cord was tethered. And it's a very small operation. It really is pretty safe and very small, in the good hands of a really good pediatric neurosurgeon. So that's one. The second one is that we don't know which kids have real muscle. So that child from Pakistan I was talking about had a tethered spinal cord, detethered it. In the operating room, we were monitoring the spinal cord. The spinal cord function came back in the operating room a little bit. You could see it from the neuro monitoring. And then I walked in the room right when he was cutting it. And then after that, the child got some function that he didn't have before of his lower extremity. Now I got an MRI before that of the quadricep to see if he had any quadricep, because there's a disconnect which happens sometimes between the top of the quadricep and the bottom of the quadricep. Because I felt it, functioning, but not firing below. So I got an MRI, and the MRI showed me I didn't think there was any quadricep muscle. I didn't see any muscle on the MRI. It looked like fat to me. And then I did the detethering, did some therapy, did some E-stim or A-stim, whatever they're going to talk about with you, and the child has quadriceps. So an MRI can underread a muscle on a patient with arthrogryposis, because it looks like, because there's some fatty infiltrate, and the MRI can underread it, which I'm just learning actually. So talking about the things that I'm thinking about is like, what can we do about nerves in young kids? There are some surgeons who want to release them. Some surgeons in Germany are taking an intercostal nerve, a nerve in your chest, and moving it to a biceps. Is that going to work if you do it early enough? What child do you do it for? So those are the questions. I have many questions, but those are the questions that we're thinking about all the time to try to understand, can we do more than we're actually doing? There's no question that I see when I release the nerves of the legs that they have been compressed and squashed. So I think about it. Let's say the condition in this child, in this specific child, is scarring or fibrotic bands. You know, the bands are like very thick fascia. Well, then that could actually compress the nerve. So if the nerve is released early on, maybe the muscle's still there a little bit, it can start functioning. So these are, I'm not sure exactly, but those are the things we're thinking about for the future. So I will take questions for whatever number of minutes you want to ask me questions. And thanks for listening. I hope I helped in some way in trying to give this lecture. Is anybody else freezing? Yeah. Okay.
I have two questions. I was wondering if you could just kind of reiterate the hip. You said something about release the muscle and let the pelvis release naturally. Is that for, like, if I talk specifically to my daughter, there's one hip that's dislocated. So by doing that type of procedure, would she be in a spiking back?
That's a great question. So the question was, because I'm going to repeat for Facebook, I'm just going to repeat your question. So the question is, you know, in hip flexion contractures or hip flexion in general or dislocated hips in arthrogryposis, how do you deal with that flexion contraction? Will they be in a hip spica cast? So number one, you have to see what is the reason why the hip is stuck in flexion because of the dislocation. So if a dislocation has great motion, then leave it dislocated, honestly. If they're both dislocated, leave it dislocated. If they're really moving well. But I've regretted not putting hips back in. So if you can get a hip back in the joint, but you keep the motion, then keep it motion. You've got to use a spica cast in arthrogryposis very, very carefully, because the hip will get stuck wherever you put it. And that's not helpful. The x-ray looks better, but the child doesn't. So there's ways of reconstructing the ligament where either you put them in a spica for just 2 weeks or less, and then get the hip moving. So if the cause of the flexion contracture, if the cause of the contracture is soft tissue, then, and the hip is located, then treat the soft tissue. If the reason the hip not moving is because it's dislocated, so I just treated a child from Ireland who couldn't flex their hip up. And it's because the hip is dislocated. So that hip I'm putting back in, and I'm only keeping the child, which is also detethered, and I'm only keeping that child in the cast for 2 weeks. And then I'm going to start it moving. I'd rather re-dislocate, really, than have a stiff hip. The reason I'm doing the surgery in the first place is because she can't sit. She's 6 years old, and she can't sit in a chair. She can't sit on the floor. She basically is a board. She's stuck. And that's she can't even sit on the mother's lap. She has to sit like this. So, and that's both hips. So I did both hips, and basically I'm going to get her moving right away, and the therapist is going to work with her starting this week. So that's the answer to that question. So it's very, very dependent upon what's causing the hip not to move. Most of the time it's not dislocation, but at times it is. No, go ahead.
I don't want to take it for anyone else. So.
No, go ahead. One more.
Just about the ankle. So you said that keeping the ankle stiff. Is there a specific age that you think that you should get to that point?
Yeah, that's a great question. So the question was for the people on Facebook is that what is the timing of trying to get the foot? You know, I don't use the word fusion because it's a bad word. But what time do you bring the foot into position and fix it in position? And what age is the best age to do that? And then, so the answer, there really is no best age. I mean, I guess you do lose some growth plate on the bottom there anyway, when you do that. So you want to do it older. If I answer, I'd say 9. But the real answer is, how bad is the foot? How much is that impacting the child's ability to walk? How many times are you going for casting and surgery and it's failing? How many times are they rotating the tibia and doing this and doing that and it's just not working? So that's my answer. It's like, if it's really impacting the family and the child's life, then let's do it earlier. I've done it as young as 5. I mean, the child did not want to go for casting anymore. The child had 3 clubfoot surgeries, 2 osteotomies of their tibia, and the child said, we can't do this anymore. We can't keep on moving to to Philadelphia or moving to Wilmington, Delaware, or moving to West Palm Beach to have this done, right? We just can't keep doing it. And so I fixed it, and they're fine. You're welcome.
First of all, you mentioned looking for the quadriceps on the MRI, and the MRI will show you whether you had it. Is there a way to figure that out?
So the first question is there a way to figure out if someone has muscle or not? You know, and the reason the cause is because the MRI is not always specific. Yeah, I think there is. And I do think that, you know, your therapist can really help you with that. And they can do e-stim, and they can do that. And they'll tell you. I mean, I like Fran and I were seeing a child also from abroad a while ago, maybe 6-7 years ago. And the child was very young, an infant. And all we saw was a flicker of biceps. A flicker. And we knew the child would have biceps down the road. So that flicker, and the child now can eat, do everything. We never did anything for her. So I think that the therapist can really be your guide with you, because they spend much more time than surgeons who walk in and walk out of the room. I think that they can really tell you, yeah, there is a quadricep, you're wrong. And I spend a lot of time looking for quadricep muscles. I mean, I ask for, like, have them try straight leg raise. I ask them to fire the muscle. And I usually know if there's a quadricep, but I'm fooled, because you don't need a great muscle to walk without AFOs. I mean, to walk without long braces. So I'm fooled by it. So I think the exam is the better way. And I really like Dr. Z's mention of, you know, looking for that latissimus clinically. The problem is that if there's one muscle that can mimic it called the teres major, and you can't use that to transfer because it's not long enough. But he just told me there's a cough test. You put your arms under the armpits of a child, ask them to cough, and feel the muscle, only muscle that fires when you cough is the latissimus. Who knew? I learned it 5 minutes ago. So I want to have people coughing COVID in my face for the next yearly month. Second question?
First question. My daughter had it done, like you mentioned, and she's 19 and wears and she's okay with that. But is there a procedure that will help fix that?
Only ankle fusion. At that age, it depends. If they had a posterior tibial tendon functioning, then that's a muscle on the inside of the foot. You could transfer that for ankle fusion. And most people who have dropped feet as adults want ankle fusions. They want their ankle fixed in place if they don't want to wear braces. So adults will come to me post-stroke. Adults come to me Charcot-Marie tooth disease, peroneal nerve injuries, and they want their foot fixed in place. And that's the only way to get rid of the brace. And they do want that, but not everybody. And some people are right, are not that vain, and they're willing to walk with braces, and that's great. That's fine. Fran.
I just wanted to address the quadriceps issue, and we will discuss this in our lecture, but we kind of assume it's there until proven differently. So we work for it, and we'll talk about this afternoon, but you don't know. They're stuck, they're locked, so they've never had the opportunity to move it. And so it hasn't had the opportunity to hypertrophy or get thick and get strong. So again, we assume it's there until absolutely proven. And
what Fred says is that you don't know if the quadriceps is there until afterwards. It's true, because if you flex your knee 100 degrees and just fix it there and try to fire your quadriceps, I can't. I'm not sure exactly how to do that. If you fix it all the way flexed and then try to fire your knee, if it's fixed in that position, it's not an easy muscle to know if it's there. So I agree. Anybody else? All right. Yes, go ahead.
How are you
Doug.
passing on this information into medical school for upcoming doctors? Because, you know, it's 20 years, usually, and 20 years. I love what you're doing, but it needs to be for future too.
Okay, so Doug has insulted me because I turned 60 this year, so he's decided to insult me. No, the question is, how are we getting this word out there? And actually, that's really interesting, because the question was, how are we going to actually pass this on for generations, or generationally, how do you pass this on, and how do you pass this on to medical schools and doctors? And that's a phenomenal question, because I mean, my father just passed away, so I have this feeling like, how do you pass knowledge on? How does that knowledge not, go with you? And I can't agree more. And I think that I think physicians speaking to each other, number one, is the most important. And sharing with each other in a non-judgmental, non-egotistical, learning from each other is one way. Trying to publish, which we do now, is another way. And I think having a meeting, as I told you before, trying to pass this on. But there is a disincentive for surgeons to do big surgery right now, coming up. It's a disincentive based on the way medical care is. So I get patients from England because the medical system of England would rather buy a 2-year-old child with arthrogryposis or a $50,000 wheelchair than have me get the child to walk. And that is 100%. I actually had to go on the TV of Scotland in Edinburgh, where I was told I was just doing it for the money, which I did for free. And because I basically was telling them they didn't want the child to have a surgery to get him to walk. I knew I'd get her to walk. And literally it was a horrible, tragic story with the mother and passed away. And it was this tragic story of this 4-year-old child who his father was doing his best to try to get, and the National Health System of Scotland would rather buy her a wheelchair than have me do the surgery. Now she's walking. So yeah, we need our health system to believe that this was basically a prejudice against people with chronic conditions has to go away. That, I tell people, like, what doctors tell patients, and this is my pet peeve, so doctors tell patients, well, you should be happy, it's good enough. You're in a wheelchair, stop being a tiger mom. Stop being so aggressive. Just be happy with what you have. Look how intelligent he is, or look how intelligent she is, or they are, or sis is, or whatever pronoun. But basically, no, I'm being serious. Whatever person is, look how, you should be happy with what they are. But that's not fair, because if that doctor was a parent of that child, whoever they were, they would want the best for that child. Whatever they are and they want the child to be. And so, I really think that there's this prejudice against people with chronic conditions that needs to go away, and generational surgeons need to be raised to do these cases, and we're trying. That's the answer.